Hey everybody, it's Adam, and I am re-recording this entire lecture. As it turns out, there were some technical difficulties necessitating this recording. So anyway, we're going to cover the stuff we went over in class. It'll probably be a little bit quicker since I won't be dealing with questions and giving out any bad jokes. Maybe there'll be one or two in there, but we'll cover the new stuff that we did not have a chance to get to in class. So anyway, poisonings, again, anything has the potential to be a poison, but oftentimes it's going to be a matter of dose, right? So as I mentioned, water can be potentially poison if too much, causing hyponatremia, oxygen, anything really, depending on the dose that's administered to the patient. And really what you're seeing though is typically some sort of change in cellular function, change in bigger levels of as far as organ function goes, may prevent us from utilizing certain substrates, like for instance, cyanide may prevent us from utilizing oxygen appropriately, being delivered to the tissues, things like that. So lots of different processes that can happen here. We're going to try to combat that by either using antidotes or other supportive measures. So again, toxicology is the science of poisons, and basically we're kind of trying to figure out how these chemicals affect the body in a negative means and how we can go about and either mitigating those effects or reversing them as the case may be, depending on the substance. And one of the big things that we do when we're evaluating these patients for toxic exposure is going to be using toxidromes. And we know that we've covered this before, but it's these toxic syndromes, this constellation of signs and symptoms that are very consistent with a particular type of exposure. So for instance, if you get exposed to an opioid, you would expect them to have myotic pupils, you'd expect them to have respiratory and CNS depression. That would be very consistent. If you saw someone who came in after a reported opioid exposure and they were, actively vomiting and were very agitated and being kind of aggressive with the staff, that's not something you normally think. You think, hey, maybe this isn't really consistent there. They appear to have some other sort of toxidrome. And so it's important to be able to delineate those out so that we can kind of get a better idea of when history is not clear or the patient's lying to you, kind of what's going on. So the way we're going to manage these toxic exposures is primarily going to be first off with decontamination, try to eliminate further exposure to the substance if possible. And then we'll talk about initial management strategies, namely the ABCs. History and physical examination. Again, history is oftentimes lacking in these cases or could be inaccurate. So it's always important to try to get as much info as you can from the patient or from people who are around the patient potentially. So that includes family members, obviously, but also like EMS can also be a good source for bits of history, especially like the environment the patient was in. We'll talk about some cases where laboratory analysis can be useful, and then if appropriate, again, there's a lot of substances that don't have antidotes, but we can administer those if they're available. And then we can also cover enhanced elimination, mainly how do we get the substance out of the body more quickly than we would if just given the patient, eliminate themselves to the kidney or liver or wherever. So as far as decontamination goes, it's always important to remember ABCs. You generally are going to be coming first here. In a lot of cases, you're going to find certain substances can make the patient not really be protecting their airway very effectively. And so in those cases, you do have to consider intubating because, again, that helps to protect the airway to prevent any potential aspiration of substances or GI contents from getting down into the lungs. Now, gastric lavage is one means of instilling either normal saline or water into the GI tract and then removing that via suction. Again, normally done through a pretty large diameter NG tube or OG tube. Again, we don't do it very frequently. It has to be done within an hour of the ingestion, typically, unless it was something like an opioid or an anticholinergic that slowed down the GI tract. But it's not done frequently, right? So it's pretty labor intensive, and really you don't get a whole lot of return on your investment, so to speak. So even if the ingestion occurred, 30 seconds ago, you're not going to be able to pull out all of the substances in the stomach because, again, some of it may pass through pylorus. The method of suction is just not really great for a lot of substances. So, for instance, the holes on the tube that you're going to be placing in the patient aren't really that big, and so large tablets, large substances are not able to get through those holes very easily, and so those wouldn't be returned at all. Versus like very small tablets or things that are already in a liquid form may be a little bit better off being able to pull that out. But it's important to remember the contraindications for gastric lavage. Again, if there's any kind of caustic substances, so acids or bases, if there was foreign bodies, you would not want to do this because, again, if it gets down in the airway, it can be a big issue. And really, we reserve this for more life-threatening and sort of ingestions, right? So a typical like acetaminophen ingestion, probably not really going to warrant lavage. Charcoal, on the other hand, is done very frequently. Again, this has the same caveat that you have to do it within an hour or up to 2 hours if you have something slowing down the GI tract. Typically, it's a given PO, but again, a lot of patients may not really like the texture of it. It's very gritty. So in those cases, you may have to give it via NG tube. But similar contraindications as far as the lavage. So again, no caustic substances, no foreign bodies. And it's important to know what charcoal doesn't work on, which is going to be things like metals. Also, alcohols tend to not really be well absorbed by charcoal. So those are the biggest things. So just remember the time frame is really important here. Obviously, the patient's an aspiration risk. If they look kind of seen as depressed or if they've been vomiting, maybe charcoal is not the best option for them in those cases. And then obviously if there's any skin contact with the substance, you want to decontaminate that as well. Water works in a lot of cases, but soap and water or like a dilute bleach solution tends to be much more effective, especially for more kind of lipophilic substances or more basic substances. But remember, with your especially larger patients, get into the folds and make sure you get rid of any substance that may be kind of hanging out there, because otherwise, especially with like caustic agents, you can see a lot of tissue damage being done over time if it's just sitting there and just kind of in constant contact with the skin. So of course, always treat the patient, not the poison. That goes for lots of areas of medicine, but certainly true here in toxicology as well. First off, you got to make sure you are not ruling out non-toxicologic reasons for the patient's presentation. So if there's medical stuff going on, you have to take care of that in conjunction along with the tox stuff. But as always, ABCs are going to be the biggest thing, right? So make sure the airway's patent, make sure they are breathing. If not, we can intubate and breathe for them, and make sure the circulation is good. if they're hypotensive, fluid depleted, like we can do things about that. That doesn't really change from a lot of other patients we deal with. So make sure you give them fluids. Vasopressors are going to be very used quite frequently, especially for like cardiac active medications. And then the other thing you always consider is like, did the toxic exposure precede something like a trauma? A lot of people drink and drive or are under the influence of other sort of psychoactive substances and cause car wrecks and things like that. So oftentimes there could be a component of trauma related, and that depends on where you're working at, those patients come your way. Obviously, cardiac hemodynamic monitoring is going to be very important here, looking for heart rate, oxygen saturation, blood pressure, all that's really good. And as I mentioned in class, I really like end-tidal CO2. Very helpful for when you're dealing with substances that are going to be respiratory depressants, opioids being one of the predominant ones there. So we can always consider if you have a patient with a depressed level of consciousness, we can give them what we call the coma cocktail. And these, again, is going to be kind of a set of substances that are, or set of therapies. They're going to be used to kind of reverse common causes for syncope or common causes for CNS depression. And so this is going to include naloxone, which we know we're going to give for opioid overdose. You can give this either IM or IV. We can give thiamine. This is going to be good for patients who have alcoholism, chronic alcoholics, chronic malnutrition. This is going to be good to help with that. And then also dextrose. Again, a lot of times you're going to have like a bedside point of care testing for glucose, like an AccuCheck. You can tell if they're hypoglycemic pretty much right away. So again, if you don't suspect there's any opioids on board, you don't have to give the naloxone. If they're not an alcoholic, you probably don't need to give the thiamine. But these are things where if you had no history on a patient, you can give all of them. And again, they're relatively safe from a side effect standpoint. So you're not really going to be faulted for potentially giving it. Just on that last slide, the other big thing is make sure you give them oxygen as well. That can hypoxia can be a common cause for CNS depression and altered mental status in these patients, especially if they have any respiratory depressants on board. Anyway, as far as the history and physical exam goes, obtain the history as much as you can. Keep in mind that you may not get the complete truth out of patients. Some of them may be just outright lying to you, but check for medications that they're on currently, medications that may also be in the home, or other substances might be in the home that could be playing a role here. Allergies are very important, and obviously we're going to be obtaining our vitals. Now, certainly physical exam is going to be very important here as well, because this tells us a lot about which potential toxidrome they're dealing with. So for instance, some of the big things that I like to hit on when I'm examining these patients is to look at the pupils. Pupils can tell you quite a bit if they're very constricted, or if they're very relaxed, and you find mydriasis, that can tell you lots of things. As far as it can be a piece of information that kind of clues you in on to what toxidrome they might be dealing with. Bowel sounds are going to be another big thing to listen to. Typically, if they are hypoactive, that makes me think of things like anticholinergics, makes me think of things like opioids. If they're very hyperactive, maybe it's more like a sympathomimetic, or maybe they're having withdrawal from, say, like an opioid, little things like that. You're also checking the skin to see if they're diaphoretic, if their skin's particularly dry, looking in the mouth to see if they're having dry mouth, little things like that. Also, the neuroexam is really important here as well. You're looking for things like myoclonus, things like that can be very helpful to tell us, okay, what's really going on here? Because again, you have to be kind of like a detective in some respects of trying to gather these little pieces of information to try to form some sort of cohesive whole of like, well, I think it's probably this, and that informs a lot of your management. So typically CBCs are not super useful from a tox standpoint. However, again, you don't want to rule out medical stuff. So if the patient comes in hypotensive, altered, it could be sepsis. You got to rule stuff like that out. And so CBCs can be good for that. Electrolytes are going to be really important here, especially potassium is going to be really important here. Sodium is really important here. Those things you want to look at. BUN and creatinine tells us what the renal function is doing, seeing if they're not able to clear a potential substance due to creatinine clearance being pretty low. Anti-gap is very important to tell us that there's any kind of metabolic acidosis going on. So for instance, with aspirin or with iron or other things like that, you can definitely see an anti-gap develop. And so remember that mnemonic that we use for wide anti-gap metabolic acidosis, that's going to be the mud piles. And so again, that's methanol, uremia, diabetic ketoacidosis, paraldehyde, iron, isoniazid, lactic acidosis, ethylene glycol, and salicylates. And then there's even a CAT mud piles. The CAT normally stands for cyanide or carbon monoxide, alcoholic ketoacidosis, and then toluene, which is a substance found in paint strippers. But again, some of that stuff you can roll out pretty easy. So for instance, if they come in and they're hypoglycemic, it's probably not DKA, right? But that anti-gap can be very useful to tell us if there's acidosis going on. ABGs can be good from that standpoint as well. It tells us especially if there's any kind of respiratory issues going on there. We use ABGs all the time for especially like aspirin ingestions because we know it's going to cause respiratory alkalosis. Serum osmolality is good for substances that are providing extra osmoles in the blood. So for instance, and osmolar gap goes right along with that, ethylene glycol, ethanol, methanol, all of those things are going to be increasing the osmolarity of the serum. And so if we get a calculated osmolality, which is usually based off of the sodium, the BUN, and the glucose, we factor in ethanol as well, because a lot of times these patients are drinking. And then we subtract that from the actual measured serum osmolality. That tells us there's some sort of gap there or something going on. Usually a value greater than 10 tells me there's something floating around that I'm not accounting for with my calculation. And so that kind of clues you into maybe a possible exposure to one of those toxic alcohols. I mentioned glucose is really important here, especially if there's any like diabetic medications that might be on board. Urinalysis can be somewhat useful. Occasionally, not super often. I don't usually recommend urinalysis necessarily, but we could look for things like calcium oxalate crystals if they had like an ethylene glycol ingestion. Urine drug screens, I typically don't really recommend that often because very often they don't really contribute to my management for the patient. And again, if you're going to order a test and if the result really doesn't change your management, what was the point of doing it in the first place? Salicylates, you don't always have to get a salicylate level. Certainly if the patient looks like a salicylate patient, and I'll talk about that in a few minutes here, you can get it. Some people just go ahead and get it as a kind of a knee-jerk thing whenever you have a tox patient, but it's not abused or not used as often as one might think, especially in comparison to acetaminophen. With any intentional ingestion, you have to get an acetaminophen level, even if it was something like they drank radiator fluid and they didn't have any exposure to medical substances, drugs. You still have to check an acetaminophen because it can be pretty silent for the first 24 to 36 hours, and so you don't want to miss that sort of thing, right? Because again, time is not your friend when dealing with acetaminophen typically. Checking ethanol, generally, especially if they have any kind of altered mental status. EKG is going to be very important as well. Typically, we're looking for rhythm. We're looking for prolongation of QTC, prolongation of QRS. Those are the big things we're looking for there. We don't have to recommend a lot of x-rays necessarily. If you have something that's radiopaque like a metal or something, you may want to go ahead and do that. So for instance, if a kid swallowed a battery or a coin and you want to localize it to see if it's gone to the stomach, that's usually where we recommend that, but not done frequently. And then lactate can also be good to help you out with looking at the acid-base status and kind of seeing if there's something going on from that standpoint. So again, antidotes typically either halt the progression of disease in a lot of cases, or they will reverse the effects of a toxin. The grand majority of substances out there do not have an antidote. We'll talk about specific examples here where they do have antidotes a little bit later, but just know that all of them have certain indications on when to give them, and it's important to understand when to use them and when not to use them. And that's where things like Poison Center can be really helpful with that. All of them can be potentially toxic if used incorrectly. Some of them, are pretty benign for the most part, but some of them can actually be really dangerous if given wrong, and so you have to be really careful with those. So, as far as enhanced elimination goes, typically this is going to be where we're manipulating the body in some way to try to get rid of the drugs or the substances faster. Some examples of this would be things like alkaline diuresis, where you'd use sodium bicarbonate D5 and basically try to get the serum, get the urine pH up to somewhere around like 7.5 to 8, and that will help to block reabsorption of a lot of weak acids. So things like salicylates and phenobarb tend to have increased elimination when you alkalize the urine there. And we can also do hemodialysis. That is going to be really good for small molecules that are more water soluble and not protein bound. And so typically we'll do this for things like aspirin, we'll do it for lithium, toxic alcohols. Those are all very much amenable to hemodialysis, and we will make that recommendation with some regularity there. All right, so the first substance we're going to talk about here is going to be acetaminophen, or APAP as it might be abbreviated. We'll kind of cover some of the clinical manifestations and the stages of toxicity here. Just keep in mind that hepatic toxicity is classically the big thing you're thinking of when you think acetaminophen toxicity. We'll talk about labs we're going to be using here to evaluate these patients, and then also our treatment. So typically what you're going to find is that acetaminophen ingestions tend not to have a lot of, that doesn't really have a toxidrome associated with it, especially very early on. You can take really large doses of acetaminophen and not really have much else than just some GI upset in a lot of cases. You see here, like in phase one, very early on, this is usually the first 24, 36 hours, malaise, vomiting, diaphoresis, really kind of non-specific stuff. It's very easy to kind of miss this, especially if they had a lot of other concomitant substances that were on board at the time. The trick is, though, is that time, again, as I mentioned, is not really your friend with acetaminophen, because the earlier you can start the antidote within reason, the better off you're going to be. Because if I start it up when I'm starting to hit into phase 2, when more of the hepatic damage has been done, or even phase 3, when they're kind of having, they become very jaundiced, they're having coagulopathies, you're kind of behind the 8 ball in a lot of cases. So it's really good to catch this early, and this is why I mentioned anytime you have an intentional ingestion, you have to get an acetaminophen level. So stage 1, typically the first 24 hours or so, could be up to like 36 hours. Again, you're not really going to see a whole lot. And again, even 12 hours might be early for some of the transaminases to start to increase. It may even be more like 24 hours before you really start to see that. Stage 2, though, is when you're going to start to see more of the symptoms become manifest, because again, Tylenol is not the main toxic component here. It's going to be that NAPQI that gets formed as a metabolite. Normally our liver can process acetaminophen within certain limits, but when you exceed that, that's when that NAPQI starts to form, and that's when we're going to start to develop hepatic damage. Basically, it's going to start to denature proteins. It's going to trigger apoptosis. That's why you see all those liver enzymes start to spill out. During that phase 2, though, that's when you're going to start to see right upper quadrant pain. That's where you can see more nausea, vomiting starting to increase here, and definitely the transaminases are going to be heading up, right? And then stage 3, this is where it gets most severe. This is usually, around the 3-day mark or so is when we're going to start to have hepatic necrosis. You're going to have jaundice. That NAPQI, once it starts to get out of the liver, it doesn't really specify whether it wants to interact with a hepatocyte versus a renal cell, and so it can cause renal failure, it can cause encephalopathy, it can cause coma, death potentially, and so we're really trying to avoid that late stage. Sometimes patients present already that far out, which is kind of a bummer from a treatment standpoint, but in some cases they can make full recovery. But if we can start at stage 1, that's always going to be better from the long run, or in the long run. So as I mentioned, that metabolite's the main toxic constituent of acetaminophen, that NAPQI, and you can actually find some patients are more likely to produce a higher amount of it, namely patients who have chronically kind of ramped up CYP2E1, which are going to be things like chronic alcoholics, patients who are on phenytoin, isoniazid, cidofovir, anything like that. So those patients might have a lower threshold when they would actually start to manifest toxicity. The way we're going to measure whether or not we need to, or to determine whether or not we need to treat our patients with the antidote is going to be with the Rumack-Matthews nomogram. And so this is a key point here, is that you don't check the acetaminophen level until 4 hours after ingestion. You can check it before then, just to confirm exposure or to rule out exposure potentially. However, this is really only going to be useful from a treatment standpoint if it's 4 hours after the ingestion. Keep in mind, this is only going to tell you whether or not or this is only good for single acute ingestions. If someone's been taking, say a gram of Tylenol every hour for the past 48 hours, this nomogram is really not going to be that useful for it. However, if a patient just took a whole handful of Tylenol now and then in 4 hours, that's when that nomogram can be very useful to determine if you need to treat or not. In a lot of cases, if you're not sure, if the history is not reliable, we typically go the conservative route and just go ahead and treat with the antidote, and then we can reassess. Again, there's very few side effects seen with the antidote, so oftentimes we just say, well, let's go ahead and give it, and then we can see how the liver is doing in 24, 36 hours and kind of reassess to see if we need to continue or not. So here's the Rumack-Matthews nomogram. You'll notice that I updated this picture here because normally here we're working in the units of microgram per ml, so this is just what I'm more comfortable with. I believe the other one was like in micromoles per liter, which you might see used in other places, but not normally in the US. Anyway, the other thing you'll notice on this this table, again, this is just the British name for acetaminophen. That's the name they use over in the UK. So looking at the Rumack-Matthews nomogram, notice here, and this is just based on the studies they did, they started at 4 hours post-ingestion. You'll see here that any level above 150, and this is basically the possible hepatic toxicity line, right? So anything above this line, you would go ahead and consider treating with N-acetylcysteine. If it's below this, then you don't have to worry about it. So if I know a kid got, a one-time single ingestion based on the history from mom, and I'm pretty comfortable with that, and the kid comes in at 4 hours after ingestion and it's 50, it's high, but I don't have to treat that. I don't have to give the antidote. On the other hand, though, if it's above 150 at 4 hours, then I definitely have to give it. And certainly anything higher than that, I would go ahead and treat. Again, we are a little bit more conservative here in the US, and so we probably end up over-treating more than anything. But again, the side effects are pretty limited with the drug, and the issues with missing a true case of hepatotoxicity is severe enough that we want to be more on the conservative side, right? We don't want to risk anyone developing fulminant hepatic failure. And again, if you're not sure, if you don't have a very good history, you just have to treat. You just have to kind of give them 24, 36 hours worth and kind of see how they do afterwards, or kind of see what their labs are doing. But anyway, so again, this is working off of a 4-hour half-life essentially for the Tylenol. So again, you can say, okay, well, 4 hours is 150, but what if your patient presented, say, 8 hours after ingestion? Well, you can just go ahead and follow the line, and it's usually around 75 here. You would go ahead and administer the drug, anything above 75 mics per ml, 12 hours. Again, it's usually another half-life, so it's like 37 and a half. And so you can track it out all the way to, basically where the level will be 0. Obviously, if it's 0, you don't have any idea when it turns 0, so you can't really use that information. But we will do that very frequently, and so we'll make usually kind of worst case scenarios where we say, well, what's the maximum amount of time this patient could have ingested this, and then backtrack that to see, would they have been at a level high enough to go ahead and need to treat at that point. So again, we're probably a little bit more on the conservative side and probably overtreat, but this is normally what we're going to use to help us make those decisions. So anyway, as I mentioned, you can get a level earlier than 4 hours, but you can't plot that on the nomogram to know if they're going to develop toxicity or not. You have to wait for the actual 4-hour level there. And again, if you're not really sure, you just have to basically treat at that point. Now, decontamination should be used if appropriate. Usually it's going to be with charcoal if it's within an hour. However, a lot of acetaminophen ingestions are also have concomitant opioids on board, so think about things like Percocet and Lortab. So because of that, it can slow down the GI tract. Sometimes 2 hours is appropriate, right? It just depends. Listen for the bowel sounds. If they're definitely slowed down, yeah, I would probably go ahead and give it at 2 hours after ingestion. Now, N-acetylcysteine is our antidote here. It's going to help to detoxify that NAPK, and it's also going to be helping to replace a lot of the cofactors needed for metabolizing that Tylenol in the liver, glutathione and things like that. Obviously, we're going to treat any acetaminophen levels that are above the possible toxicity line. And then if we're not sure if they have a positive acetaminophen level, or if we have a history where we think it could have been an ingestion, even at the level 0, but the LFTs are increased, then we'll go ahead and treat at that point. We can also treat based on the amount ingested in some cases. So if you have a history of someone ingesting more than 7.5 grams, again, you didn't have levels that were available at the time, that could also be a safe bet that you probably need to treat at that point. Now, there's 2 options to give this. We can either do IV or PO. A lot of cases, we are more moving to use IV management because, again, PO has a lot of sulfur in it. It smells like rotten eggs. A lot of patients do not tolerate this well. You can put it into orange juice or some sort of citrus-based drink to cut down on that smell and cover it up and use a straw. However, some patients don't do well with that. And if they vomit within an hour, you have to repeat it anyway. So it kind of really stinks for the patient from that standpoint. But normally we would give 140 mg per kilo PO load, and then 4 hours later we'd start doing 70 mg per kilo every 4 hours for 17 doses. So when the oral's all said and done, basically 72 hours worth or 3 days worth of therapy there. For the IV regimen, though, you can actually get away with using a 21-hour regimen, in which case we would do 150 mg per kilo over 1 hour, followed by an infusion of 50 mg per kilo given over 4 hours, and finally a 100 mg per kilo dose given over 16 hours. So 21 hours total, and basically you get the same general efficacy as you would with the oral regimen there, which is kind of nice. Again, you always want to give this preferably within 8 hours of the ingestion, because we find that it's 100% effective if given within that time frame. If it goes beyond that, it's not to say that it's ineffective, it's just that you're going to have some reduced efficacy in a lot of cases. Up next we have aspirin, and so typically you're going to either see this as being like an acute ingestion for an attempted suicide, or like a kid's gotten into it. Sometimes though you'll have kind of chronic overdoses that occur due to patients kind of taking medicinal amounts, say, or therapeutic amounts multiple times a day. So, I mentioned we have one patient who was taking aspirin every time he had chest pain, and he didn't have very well controlled angina, so he was taking quite a bit, many episodes of chest pain a day, and of course ends up with aspirin toxicity. So it's one of those things where you may see certainly a fair share of attempted suicides. However, in a lot of cases it could just be inadvertent overdoses due to misunderstanding how they're supposed to take it. So the big thing with aspirin is that you're typically going to see a mixed respiratory alkalosis along with a metabolic acidosis. That's the most common thing you're going to see with this. So again, early on, you're going to find that the aspirin is going to stimulate the respiratory drive. So you're going to have a respiratory alkalosis because you're breathing off a lot of CO2. The kidneys try to compensate for that alkalosis by peeing out bicarb. So you end up developing urinary alkalization. The body basically does it itself. But unfortunately, what aspirin is also doing in the background is uncoupling oxidative phosphorylation. So you kind of switch from aerobic to anaerobic metabolism. We know that produces a lot of acid, and so then you don't have a lot of bicarb to combat that since you peed it out earlier. And so now you get this metabolic acidosis on top of respiratory alkalosis. And these patients can start to circle the drain pretty quickly. You know, they can look good for a while, and then they just kind of tank on you after a period of time. So they can become very sick very quickly. So aspirin cases can be pretty scary in some cases. You can also see things like, you know, pulmonary and cerebral edema that can occur, coagulopathy potentially, but the acid-based disturbance is the big thing you're going to notice. Acute, you know, you can see a lot of GI effects from this, a lot of nausea, vomiting. Certainly, the tachypnea and tinnitus are very consistent with aspirin. So again, it's kind of tells you the sort of toxidrome you're going to expect to see with aspirin. So that's one of those things where, you know, if I didn't see these things, you know, if they weren't diaphoretic, they weren't tachypnic, no tinnitus, you know, I probably wouldn't necessarily need to get an aspirin level because it's probably unlikely to be, you know, high in my differential. However, you know, if they're experiencing this, I'm definitely checking an aspirin. With more severe toxicity, as you see, certainly coma, seizures, you know, especially as the aspirin, as you get more acidotic, the aspirin is more likely to penetrate the blood-brain barrier, right? Because remember, light like and aspirin's weak acid, so it gets into the blood-brain barrier easier as you get more acidotic. So yeah, so that's where the CNS manifestations can be very dangerous, and that's oftentimes when you're going to see the patient really crump, is when they get very acidotic and all the aspirin goes into the CNS. So typically doses greater than 160 mg per kilo are considered toxic. And as far as drug levels go, normally anything above 30 mg per ml we would consider potentially toxic as well. And that's when you're going to start to see that respiratory alkalosis start to develop there, right? Typically the higher the levels, you may not see a one-to-one correlation between that and toxicity, but typically the higher the levels are going, the more likely are to see toxicity develop, especially when we start to get to numbers around like 70, 80, 90, and even 100 mics per ml. That's when patients are definitely going to get more and more sick. That's where you're going to see more of those CNS manifestations. And once the aspirin's in the brain, it's hard to get it out in a lot of cases. So that's why we're going to do serial levels for these patients. So you're going to get a baseline level, and then usually every 2 hours, we'll continue to get levels to see kind of where it trends. Typically, like to see a peak, and then you want to see downward trending of the levels before you can stop getting any more blood draws at that point. Now, as far as management goes from decontamination standpoint, activated charcoal is totally appropriate here. And then we'll also do that alkaline diuresis. So this is where we're going to do sodium bicarb and D5, try to push that urine pH up to 7.5 to 8. It may already be alkaline depending on what stage the patient presents in, if the kidneys are already starting to eliminate bicarb due to that respiratory alkalosis. And the other thing is make sure to correct fluid deficits. make sure they are, tanked up, help maintain the blood pressure and whatnot. And then as the levels start to climb, especially getting close to the 100 mic per ml mark, that's when we will do dialysis. So we can actually recommend that, and the nephrologist will help us out, get the dialysis started, and usually a 4-hour round, and the levels will be undetectable afterwards. So a very good way to pull that aspirin off. But since hemodialysis is not without risk, we don't always like to jump to that. So definitely alkaline diuresis with the potential for dialysis if the levels are high enough, or the patient is developing a lot of, say, refractory acidosis, or if they develop seizures, anything like that, there's really severe intoxications, that's when we'll go ahead and do dialysis. Up next are going to be the anticholinergics. Now, there's a ton of drugs that are going to cause anticholinergic toxidromes, and we know that mnemonic is going to be the mad as a hatter, dry as a bone, red as a beet, uh, hot as Hades. I saw one that said full as a flask, which I thought was pretty good to show urinary retention. But lots of agents do this, right? So you're going to have pure anticholinergics, things like atropine, benztropine, a lot of antihistamines, especially the first generation, can do this, Benadryl being a big one. All of your antipsychotics, antispasmodics, cyclic antidepressants, any of those can cause an anticholinergic toxidrome, right? Even some plants, especially here in Florida, we have things like Jimson weed and angel's trumpet. So these can look a lot like some pathomimetic sort of ingestion, like cocaine or amphetamines. The big differences here is going to be things like urinary retention. Typically, they're going to have hypoactive bowel sounds, and typically they're going to have things like dry mouth, dry skin. That can kind of give you a clue this may be more of an anticholinergic. But certainly, if they're abusing it for, in order to get high, they'll typically be experiencing things like hallucinations. At low doses, you may see some sedation, but they tend to get pretty agitated, pretty aggressive as the doses continue to climb until they develop seizures. Again, charcoal can be good here to manage these patients. You can use it up to 2 hours because it will slow down the GI tract. However, it may not be done frequently due to mental status and them being able to protect their airway. Benzodiazepines are definitely the drug of choice for the seizures. The agitation can actually help out with the heart rate to some degree as well to try to calm that down because these patients will be tachycardic. But for refractory symptoms, you can use physostigmine. We mentioned this is a reversible acetylcholinesterase inhibitor, so that will bump up levels of acetylcholine. That will start to kick off the anticholinergics from the muscarinic receptors and allow it to start to work again. Again, not done super commonly due to some stigma against the drug itself, but very good if I have a refractory patient who's not responding to benzos. Up next, we're going to talk about our cardiovascular drugs, including things like digoxin, beta blockers, calcium channel blockers, etc. So the first one we have here is Digoxin poisoning. Again, you may think of just the drug, but there's also several plants that grow here in Florida which will cause digoxin toxicity, including things like oleanders. So next time you're driving along like the 528 or the 417, if you look at the medians, all those really kind of brightly colored plants are typically oleander, and those actually contain digoxin-like compounds. As far as toxicity goes, typically you're going to see a lot of GI effects up front, usually for acute ingestions, and then you can see things like altered mental status. You can see yellowing of the vision. You have these halos around lights and things like that, that xanthopsia I've mentioned before. But the big toxicity we worry about are going to be the cardiovascular effects. You're going to see typically bradycardia. You can see things like first degree or higher heart block. You can see PVCs all the way up to VFib, VTAC. Really any arrhythmia is possible with digoxin, but typically the most common one you're going to see is bradycardia, and also along with that you're going to see some hypotension. So definitely getting EKG here is going to be super important. The other big reason why you would see someone present with digoxin toxicity is not due to an acute ingestion necessarily, but typically due to more chronic overdosing, in which case someone's been on a dose of digoxin for a while, and they either have a chronic decrease in kidney function to where the dose has not been adjusted and their levels are now super therapeutic, or they have like an acute decrease in kidney function, maybe due to dehydration or something like that, and the levels will all of a sudden jump up. That's typically where you're going to see that more like in elderly patients who are on digoxin. So our treatment is typically going to be making sure to fix the fluid issues, fix their electrolytes. Again, digoxin is going to make you hyperkalemic just based on the mechanism of inhibiting that sodium-potassium pump. And so if they already have renal failure on top of that, their potassium is probably high anyway. So that can be a recipe for disaster from an arrhythmia standpoint. So you really got to make sure to watch the potassium, make sure you're not going to increase that any further. Certainly try to control arrhythmias as best you can. It can be kind of tough from a treatment standpoint because, again, adding on more antiarrhythmics on top of the digoxin may not help you or may not be as effective as you think. Really the best thing to do is going to be to give the antidote, which in this case is antibodies that have been designed to bind up digoxin. So Digibind, Digifab is used here. Typically we use this if they have, say, refractory hypotension, if they have high degree AV block, if they are developing any kind of ventricular arrhythmias, or if they have a high potassium, say like a potassium greater than 5. That's typically where we're going to go ahead and give Digibind to go ahead and correct that. And it very rapidly will bind up all the digoxin, and then the patient can just clear it out from the kidneys at a later date. It's a very effective drug, works very, very quickly. Next, we have beta blockers. As you might imagine, you're typically going to see mostly bradycardia and hypotension seen with this. Some cases you may have some sodium channel blockade causing QRS widening, but it's not a super common thing we'd expect to see. But again, you're going to get an EKG in these patients anyway, so you can monitor for that. The more lipophilic beta blockers tend to cause more CNS manifestations. Like propranolol is the one I think about frequently. Getting up into the CNS can cause seizures in some cases, so you got to be careful with that one. The other big thing you can see potentially is bronchospasm. This is going to be more the non-selective beta blockers, so like propranolol, sotalol potentially, things like that. And then the hyperkalemia is usually pretty mild for the most part, and then hypoglycemia as well can be seen here. So as far as labs go, nothing out of the ordinary than what we would normally get on these patients when you're working them up. Certainly, beta blockers can be a life-threatening ingestion, so lavage could be considered, but not done frequently. Charcoal is done much more often. You want to correct any kind of electrolyte abnormalities, correct the glucose. If they are seizing, obviously benzos are going to be a treatment of choice here. So diazepam works, lorazepam works, any of those are fine. But the antidote we would use for beta blockers is actually going to be glucagon. And while normally glucagon is used for hypoglycemia, in this case what we're actually doing is stimulating cyclic AMP. If you do that within the heart, that can actually increase contractility. Normally our beta receptors would do that, will stimulate cyclic AMP, but since they're being blocked, we can go via a sort of backdoor regimen, or backdoor method here. And so that's where glucagon comes into play. Typically we'll give them a bolus of glucagon, and if we see the blood pressure and the heart rate start to recover, then we'll go ahead and start them on a glucagon drip. So again, think beta blocker toxicity, think glucagon as being the antidote of choice. Now, calcium channel blockers can have a little bit of different flavor depending on which agent you're looking at. Typically, if you're dealing with the dihydropyridine, amlodipine, nicardipine, nimodipine, they will have hypotension and probably tachycardia. I've seen massive ingestions where they cause bradycardia as well, but typically you're going to see tachycardia due to that decrease in SVR in your heart trying to increase cardiac output to try to balance out the equation there, right? For non-dihydropyridines like verapamil, diltiazem, that's where you need to, or you're going to expect to see bradycardia hypotension, because again, they're going to be direct cardiodepressants in addition to vasodilators, okay? Other thing you can see is going to be hyperglycemia, and that's going to be due to suppressing insulin release in the pancreas. So again, one of those things, if we don't know what sort of toxicity the patient has, what sort of drugs he might have been exposed to, and we know it's something between, it's down between a calcium channel blocker and a beta blocker, oftentimes we'll look at the glucose, and if they're hyperglycemic, that'll lead us to think calcium channel blocker. If they're hypoglycemic, that'll lead us to think beta blocker, right? So anyway, as far as management goes, lavage charcoal is appropriate here. Definitely fluid challenge. Vasopressors are going to be very useful here. Oftentimes, for really big ingestions, I've seen them use multiple pressors at the same time. So being on dopamine, epinephrine, phenylephrine, norepi all at the same time to try to get the pressure up. They can be very difficult to treat. Now, calcium chloride has been used occasionally. You can get some transient help in the blood pressure, but typically this is not going to be the best antidote for these patients because the effects are not long lasting. Really good pressor support, fluid support, and then also what we'll do in some cases is what we call high dose insulin euglycemia therapy, where we'll run insulin drips at very high rates. And similar to glucagon, that actually helps to increase contractility in the heart and will help to increase blood pressure and heart rate for those patients as well. Clonidine is going to have, again, a different flavor even than the other ones we were looking at already, because this one's going to be working more centrally as an alpha-2 agonist. So typically you're going to see a lot more CNS effects with this, namely, lethargy, stupor. You can see some meiosis seen with this, and in fact, a lot of clonidine toxicity can be mistaken for opioid overdose. So because of that, a lot of people were giving Narcan to these patients inadvertently thinking it was an opioid overdose, and they actually saw that it did work for some of them. About 50% of patients will respond to this. And so in those cases, we may give naloxone as a bolus, and if we see their blood pressure respond well, then we'll actually put them on a Narcan drip. And so as I mentioned, I had that one infant who was fed a clonidine patch, and we actually kept them on a Narcan drip until he was able to eliminate that through the feces. But typically hypotension, bradycardia, and depressed mental status are going to be the big things you expect to see with clonidine. Now, clonidine withdrawal can also be pretty dangerous, but it's going to be presenting basically as the opposite of clonidine toxicity. And so you'll see that patients who abruptly stop use of clonidine, you're going to see big increases in blood pressure and heart rate, can be diaphoretic and have agitation. So in order to treat that, typically we're going to be going with things like alpha and beta blockers. So we can use things like phentolamine, which is an alpha blocker, and something like propranolol or Inderal. Really any beta blocker will work here, but that will help to get the blood pressure and heart rate under control. And typically if patients have, may have a high-risk cardiac history, maybe they have atherosclerosis, this can actually induce heart attacks in some cases. So you got to be careful with these patients, and abrupt cessation is clonidine. Now, nitrate toxicity is not something I see frequently. However, the big thing you expect to see would be hypotension and tachycardia, very similar to what you might see with a dihydropyridine sort of agent. So again, orthostatic hypotension, dizziness, syncope related to that, tachycardia, is all going to be expected to be seen with nitrate toxicity. And so the big thing you would also frequently see is this as a drug-drug interaction, basically. So typically, if patients who are on phosphodiesterase inhibitors like sildenafil for erectile dysfunction. When they mix this with a nitrate, that's where you can see kind of synergistic drops in blood pressure, and we're more likely to have patients having to come to the ER to get managed there. Typically, a lot of fluids are going to be useful here to try and correct the blood pressure, and pressors may be used occasionally. Things like norepi, phenylephrine are pretty good for this. Now, nitrates and nitrites can be pretty strong oxidizers, and so in large doses, they can actually convert hemoglobin to methemoglobin, so basically it'll turn your patient blue. And so not frequently going to occur, but it can definitely happen here, especially if you have large amounts. Again, methemoglobin is treated by giving methylene blue that converts methemoglobin back to oxyhemoglobin, and thus you can then start to carry that oxygen around to the tissues that need it again. So I mentioned another helpful thing here, especially if they're having really profound hypotension, is putting them in a Trendelenburg position, so that way they at least have some fluid return back from the lower limbs back up to the head and the heart there. So up next we have our psych meds, and TCAs used to be a very common cause for suicide and accidental deaths in depressed patients. Again, back in the day, this is kind of all we had after the MAOIs were kind of the first agents, and we had TCAs, and this is very dangerous drugs. And if you remember back to our talks of psych meds, all of them carry a black box warning for increased suicidality. Remember, these patients oftentimes may have thoughts of self-harm and suicide. However, they don't really have the energy to really act on those things. But when you give them a TCA and kind of give them back a little bit of that energy, now they are able to act on them. So again, very common cause for suicide and attempted self-harm with TCAs because they are so dangerous. Their therapeutic index is very, very narrow. Fortunately, nowadays we have things like the SSRIs, which are much safer. You can take many times the normal dose and not really have any issues with it, fortunately. Big things we're going to be shooting for here are you're expecting to see hypotension due to alpha blockade. You're going to see some anticholinergic effects, similar to what you'd see like Benadryl or any other anticholinergic. And then the other thing that's really important here is going to be the cardiac effects, namely the EKG changes that happen due to sodium channel blockade. By blocking the sodium channels, the big thing we're looking at is going to be QRS prolongation, and actually by looking at that, and that'll help us to decide whether or not we need to treat with the antidote. Now QT can also be expanded here, but this is more of a result of the QRS just getting naturally prolonged. That just kind of naturally will prolong the QT as well. It's not like it's actually blocking the potassium channels like you would expect to see with something else that prolong QT primarily. But anyway, so again, VFib, VTAC are very much a possibility here, and that's what we're really worried about. So really, if the patient's going to die here, it's going to be due to hypotension, acidosis, and then preceding ventricular arrhythmias and seizures typically. So treatment has to be really aggressive. If they're going to die, they're probably going to die within the first 6 hours or so, typically. So again, this is a case where lavage may be warranted. Maybe not, just depends. However, if I'm trying to manage a patient who's potentially seizing, I probably don't want to give them, a belly full of fluid they can aspirate. So oftentimes charcoal is not given either. But you need to get a baseline EKG, and it's really helpful if you have another EKG from a different encounter to compare that to see what their baseline is. Because mainly we're looking at QRS prolongation, QT to some degree, but QRS is the big one. Now our cut point here is when we're going to manage this is going to be when the QRS level gets above 100 milliseconds. That's when they're going to be at bigger risk for things like seizures and arrhythmias, and that's when we're going to actually give sodium bicarb. Basically what we do here is by what we call serum alkalization. We give sodium bicarbonate D5 just like we would for trying to alkalize the urine, but here we're actually going to alkalize the blood. Usually we get a pH of 7.45 to 7.55, so it's not a big shift, but it is, could be for your patient if they're especially acidotic. However, by getting that pH up, that will help to reset the sodium channels. It'll help to increase protein binding of the TCAs, and will help to, reduce your risk for seizures and arrhythmias. And usually we'll start that when the QRS gets above 100 milliseconds. Again, be pretty aggressive with fluids. Make sure you're giving them vasopressors if they're hypotensive. And if they're seizing, obviously Ativan. Magnesium is good for things like torsades. Lidocaine, probably not going to be used too frequently for management of arrhythmias. Really, it's going to be just sodium bicarb. Because if you remember, lidocaine is a sodium channel blocker as well, so not really going to be the most effective agent there for managing managing the arrhythmias, I should say. Now, MAOIs you won't see too frequently nowadays since SSRIs and SNRIs are much more common. However, this is one of the things where you can expect to see certainly effects several weeks out from last use, mainly due to the irreversible nature of their MAOI inhibition. These can present with a very sympathomimetic sort of picture here because they're blocking metabolism of catecholamines like epinephrine and norepi and dopamine. So typically expect to see them prehypertensive, tachycardic. In some cases, you can actually deplete yourself of catecholamines over time and can actually end up running into issues of hypotension. But again, toxicity can be pretty long lasting, and you're more likely to see this if you were to say have someone maybe stopping an MAOI, but they were started on another antidepressant drug at the same time. That's when you're going to see a lot of like serotonin excess, and serotonin syndrome is a possibility here as well. Several phases associated with it. Really, the big thing when we're worried about is going to be this catecholamine surge that occurs here. A lot of excitation, a lot of hypertension, tachycardia, which can develop all the way into things like MI, DIC, rhabdomyolysis. But again, not frequently seen, but it's definitely one to keep on your radar. So again, things like phenelzine, tranylcypromine, things like that that we don't see frequently. Typically, treatment's mainly going to be supportive. You try to keep them keep them cool. Benzodiazepines for seizures, things like that, and then potentially antihypertensives, nitroglycerin, nicardipine, something like that, if they were to have pretty severe hypertension. Up next, we have iron. This used to be one of the biggest causes of accidental death in children, but nowadays, because of the way that these products are packaged now, it's much less likely to occur here. But it can still cause a lot of toxicity. Typically, one of the big things we need to do when we're managing these patients is to figure out how much elemental iron they got. So make sure when you're looking at these products, because again, there's lots of different iron salts that are out there. There's ferrous sulfate, ferrous gluconate, ferrous fumarate, lots of different varieties that are out there. You need to find out how much is in the elemental iron content, because that's what we're going to use for our criteria here. So based on elemental iron, usually if they get, say 20 mg per kilo or less, typically they'll have a lot of GI toxicity, a lot of vomiting. If they do vomit, ask if they had any pills in the or pill fragments in the vomitus, so that way you can determine, you redo your calculation, because the iron obviously wouldn't be absorbed if they threw it up. Usually when you start to get above 40 mg per kilo, or maybe between 20 and 40, that's where you're going to start to see more systemic toxicity, and certainly above 60 can be potentially fatal. Typically, alert patients who are presenting without any symptoms, especially no vomiting, probably didn't get actually a toxic dose of iron. Anyone who got a decent enough amount to have any significant toxicity, they're going to throw up. And because it is so rough on the stomach, you can see potentially GI bleeding, bloody diarrhea, bloody vomit can definitely happen here. Later stages you're going to find tend to present with this hyperglycemia with metabolic acidosis that can occur, usually kind of following these bouts of abdominal pain and gastroenteritis. So there's kind of several stages to it, which we'll kind of go into, kind of similar to what we saw with like Tylenol. So there's kind of 5 distinct stages here, and it's important to understand kind of where they're at within this course, because you may think, hey, patient looks like they're getting better, the symptoms are improving, let's go ahead and send them home. And that's really not going to be the case with iron. This is one of those ones you got to be really careful with. So first stage here is typically the GI effects, typically within 6-12 hours after exposures when you're going to see this first stage here. Could be bleeding associated with this, but more often than not, just normal nausea, vomiting, diarrhea you're going to see with this. Most people are not going to die at this point here. However, make sure to monitor their fluids, make sure you're tanking them back up, because again, they're going to have a lot of fluid loss due to the GI losses there. Stage 2 is just kind of latent or quiescent period, where basically they appear to be improving. And again, this may be like the next 12 to 24 hours of the ingestion. And basically what's happening here kind of in the background is the iron's causing oxidative phosphorylation to start to be uncoupled again. You're starting to have, aerobic metabolism switch over to anaerobic, and that's where you're going to run into issues in the third stage that occurs here. So anyway, so patients will present with a lot of GI effects, look like they're getting better, and then they'll really crash afterwards. Some patients may skip this stage 2, but a lot of patients will still be presenting right here. So when they get into stage 3, that's when they start to develop very serious acidosis. They tend to get hypotensive, tachycardic. They can also start to see things like seizures develop here and a lot of third spacing of fluid. So blood pressure management is huge at this point, and trying to make sure to keep their pH within some normal range, or as close to normal as you can get. You can have kind of this hepatic stage that occurs later on as well that can have some hepatic damage happening here, coagulopathy, whatnot. And then hypoglycemia can also be seen with pretty significant liver dysfunction. And then finally this delayed stage where this is where the patient's pretty much recovered, but they can have strictures form in the GI tract. You can have scarring that occurs that can actually provide really kind of long-term GI issues that the patient can be experiencing, months and years after the actual ingestion's already happened. So as far as your workup goes, make sure you're getting serial iron levels to monitor and see where it's going. Make sure it's not increasing, or at least you want to see where the peak is and then the downward trend. Especially if you're, at that point where it's asymptomatic, but you're still seeing the levels continuing to rise. That's where you want to be kind of worried for the patient. Typically, normal iron levels can be upwards of like 100, 150. When this is where we're going to start to be concerned when we start to see levels like around 300, 350. Certainly anything above 500, they're definitely at risk for death potentially. So iron levels, monitor glucose, lactic acid levels can be useful here. If there's any bleeding, certainly CBC can be useful, and then sometimes coagulation studies are utilized here as well. Other big thing to consider, certainly you get a pregnancy test. Really any intentional ingestion, you should probably get a pregnancy test for females. And then KUB is sometimes used. Remember that the iron tablets, while radio-opaque, don't always show up. It depends on several factors, usually the time frame that the patient is presenting. So if you don't see it, you cannot rule out ingestion just based on an abdominal film. Treatment, big thing here with GI decontamination is that charcoal is not going to be useful. However, you can use something like whole body irrigation with polyethylene glycol or go lightly. That will help to flush out the GI tract. And then deferoxamine is our antidote of choice that will chelate the iron and allow it to be processed normally. Normally, this will be given as a continuous infusion, and that will help to reverse a lot of the hypotension and the acidosis pretty quick when you administer this. I've had patients that are presenting, in shock essentially, and then after fluids and pressors and getting the deferoxamine on board, usually 12 hours later, they're actually able to come off of all the pressors. So it works pretty well. Just need to make sure you get it on in time to manage the patient. Up next, we're talking about lead toxicity, and so this is going to be something where it's usually based on chronic exposure. You're going to find that this is going to be more of an issue in patients who are vitamin D and calcium deficient. Lead tends to look a lot like calcium does in the body, and so this is why it gets put into, it gets deposited in the bone, which is why it has such a long half-life. basically the type of patients you're going to see, or the type of exposure you're going to see, are typically due to things like, older houses where you have lead-based paint. Normally this can happen with like chronic inhalational exposure. So for instance, you have door jambs and windowsills that are constantly having friction applied to them. That can generate dust that patients will inhale and get chronic lead toxicity. You can also see kids with like pica who are eating paint chips. Could be an issue there. Some cases you can have retained bullets and wounds that will leach lead. Some case reports of autistic kids eating bullets, which will leach lead in the GI tract. So lots of different reasons for lead toxicity. The main thing you're going to expect to see is this going to be an issue in kids who are calcium, vitamin D deficient, especially in older homes. I've seen some cases where it can be like groundwater contamination, especially out in the country. So this is why I frequently ask patients, well, do you drink well water or do you get city water? Of course, depending on where you're living at, places like Flint, Michigan, you may have to worry about the city water too. So again, typically you're going to see more lead exposure up north. We don't have a ton of them down here, fortunately. So normally we do lead screenings for almost all children. Pretty young, because again we can ask questions like how old is the house you're living in, different questions like that to see if there's a possible lead exposure. But normally it presents pretty insidiously. So classically you think about a cranky child who's just more fussy than normal. But the long-term complications are what the issue is here, where you can see decreases in IQ. You can find decreased success in school. So you really want to be able to capture this early if you can screen for it and get a lead level, and then get them out of the exposure if possible. Because again, the faster you can get them out of the exposure, the less likely they are to develop really kind of chronic, large body loads of lead. The better off they're going to be in the long run. So certainly kind of more kind of low dose, kind of chronic exposures, you're going to see some irritability, maybe poor appetite. You can even see some things like gingival hyperplasia potentially. Usually abdominal pain can be seen in a lot of cases. And then sometimes, changes in the kid's activity level, like they're just not acting right, is typically how the parents will describe them. Now, these patients tend to be iron deficient as well, and so in those cases they may present with some, may look kind of pale due to anemia, so that could be another thing you're kind of looking for. The more serious sort of neuro symptoms you can expect to see with this is typically going to be things like peripheral neuropathy, so you can say things like foot drop and wrist drop, and that's where you can also see this is a lot of occupational exposures as well. Typically kids are more often affected, but adults can still see this at higher levels additionally. So if you're, have a patient who's working with lead chronically, we had this up in Jacksonville where we had some patients who were working on the bridges. Jacksonville is known for having lots of bridges, and basically they were working on repainting it, and so the paint they use is lead-based because it's very, very pretty durable paint. So they were sandblasting it off, and they actually didn't have proper respiratory protection, ended up inhaling a bunch and had toxicity with that. So it could be occupational exposures as well, but typically those neurosymptoms are the more worrisome things. They can present all the way with like full-blown encephalopathy in some cases. It can be potentially deadly in high amounts. You can even see certain things like lead lines that can form in the gingival tissue, especially if patients have poor dental care. One of the other things you might see in the bones, actually, if you do an X-ray, you can actually see lead lines there on small children due to lead being deposited in place of calcium in the bones. That's again going to be more with chronic exposures there. Certainly with severe CNS toxicity, you can expect to see things like papilledema, cranial nerve abnormalities, and starting to see certain signs of increased ICP, worried about things like cerebral edema developing there. And seizures can also be presenting with some of those more severe CNS toxicities. As far as labs go, you want to get a whole blood lead level. Typically, anything greater than 10, and really a normal lead level in the blood should be 0 because lead has no physiologic purpose in the body. But anything greater than 10 we consider to be positive. And typically what we'll do is work with the Department of Health, and they will send out a team to actually evaluate the home, wherever the patient might be exposed to this, or if they potentially are working in a place where they're exposed to lead, they would actually remove them from the environment. Typically, kids tend to be more symptomatic at lower levels than adults do because they have kind of like actively developing brains, and they will incorporate this much more quickly. levels between, like, say 10 and 20, you're going to find that oftentimes the best thing to do is just get them out of the exposure, and then you do follow-up testing afterwards to make sure the levels are going down. You're going to find that with our chelators that we're going to talk about here in a second, that you get less bang for your buck the lower the levels are. So if you have very high levels, you can give it and get very good reductions in serum lead levels. However, when it's around 10 to 20, it doesn't really do a whole lot of good. There's been some studies to compare, giving the antidote and not giving the antidote, and there really wasn't a big difference when at these low levels. So typically, it's 10 to 20, they'll just get them out of the environment and recheck it later on. So here, when you're managing these patients, obviously fluids will be important here, especially if they're having a lot of GI symptoms along with this. Go ahead and get a blood lead level. Look at imaging studies potentially, especially if it was like an ingestion of like paint chips. Those will show up on X-ray. If it was like ingestion of a bullet or something. You can speed the elimination of this by using whole body irrigation to kind of flush it from the GI tract, try to prevent absorption, because charcoal is not going to bind up to lead here, right? We'll consider doing chelation therapy, which we'll talk about in a moment, if the levels are particularly high. So usually if they're like greater than like 40-ish, we'll consider treating. Certainly if they're manifesting any CNS toxicity acutely, we'll go ahead and treat for them as well. Anything we can do to try to eliminate any further exposure by getting out of the GI tract is going to be best for them. If it's a retained bullet, like that's something we probably want to get rid of as well, to try to make sure they don't have any further leaching of lead from the particulate. So just a point there with the lead toxicity is just know that chelation therapy is going to be the antidote for that. Not going to get specific into the actual drugs we use, but there's several of them that are available. The most common one you might run into is one called Succimer, or DMSA. That'll be used commonly for outpatient management of these patients. So for instance, if you had a kid who was being exposed and maybe their levels like in the 30 to 40 range, obviously you get them out of the home where they were being exposed to it or whatever the exposure happens to be, and then you would give them Succimer therapy. They would go on that for a couple week round. They would stop it. You allow time for lead to redistribute out from the tissues and the bone, and then you would potentially give them another round of DMSA therapy, and then you would kind of do that, this kind of cyclic sort of therapy until lead levels are kind of down in a more appropriate range. Usually less than 10 is going to be considered sufficient, or acceptable, I guess would be the term. Okay, so next we have benzodiazepine toxicity. We have kind of mentioned this before, like in the surgery section. Mainly with benzos, you're expecting to see a lot of CNS depression, coma, delirium. With benzos themselves orally, if they're just by themselves, you typically do not see a lot of respiratory depression, right? Benzos tend to be pretty safe by themselves in overdose. They'll be certainly pretty CNS depressed and sleepy, but they're probably not going to die from respiratory depression. However, if you start to mix this with other CNS depressants, as patients oftentimes do, that's where you can run into that. So if you mix benzos with alcohol, yes, absolutely, you can see respiratory failure occur with that. If you mix benzos with opioids, you can absolutely see that. So you got to be really careful when you're mixing and matching drugs from a benzo standpoint. And so many patients have these available to them. This is a very frequent co-ingestion with other opioid ingestions and things like that. Xanax is a very commonly used benzo. I have more overdoses with Xanax in the list of substances than, if I had a penny for every one of those, I'd probably be a very rich man nowadays. Now, sometimes benzos can be used as a date rape drug. If you remember, back when we were talking about the surgery meds, we mentioned that benzos can be used to help with inducing an antegrade amnesia. They can actually be abused for that as well, especially in the terms of date rape. And if you ever hear the term roofie, this actually was referring to a drug called flunitrazepam or rohypnol. And that's where the term roofies came from, was the rohypnol. And so basically it was used as a date rape drug for a period of time there. So basically the patients become kind of disinhibited, they'd be likely to make bad decisions, and then they wake up and not remember it essentially. So kind of a bad drug from that standpoint, a bad reputation at least. Typically, these will show up on urine drug screens, so that can be a way to confirm exposure. GI decontamination with charcoal is typically used here unless they are so CNS depressed they might be an aspiration risk, in which case I just avoid it. And flumazenil or romazicon is the antidote here. Basically, be very careful using flumazenil in the case of people who are chronically on benzos, because if you induce withdrawal for these patients, you can induce seizures, and that can be very difficult to manage advantage because the only way to treat that seizure is to give more benzos, right? And so you already have a drug on board that's fighting that. So be very careful giving flumazenil. If it's someone like a kid who got an accidental dose of a benzo, I feel very comfortable giving them flumazenil. If it's an older patient who has been on it for a long time, I probably would never give it. I can support them from a respiratory standpoint easily enough and just let the drug work its way out of the system. All right, so as far as opioid toxicity goes, we're starting to see a really big increase in use of heroin, especially around here in Florida. Oxycodone used to be a huge market down here in Florida. We were one of the first stops on the Oxycodone Express, but ever since a lot of the rules changed around that and a lot of those pill mills got shut down, heroin is now more cheap, and so that's where they're starting to use a lot more of that. Problem with this as well is that people are starting to cut their drugs with other substances to try to get more product out of it, essentially, right? To dilute it out, and they're using things like fentanyl, which can be very potent, and so a lot of people are dying from these heroin overdoses, which are actually fentanyl overdoses. Anywho, one of the big things you're going to expect to see with opioid exposures are going to be coma, respiratory depression, and meiosis. You don't always see the meiosis, so you can't use that to rule out exposures if it's not present. Just know that that is classically what we're kind of thinking of when we see these exposures. The biggest thing to manage for these patients is going to be airway. Intubation is going to be usually the best thing to do to make sure you're protecting their airway and breathing for them. Charcoal is fine here. You can probably even give it up to 2 hours if they have hypoactive bowel sounds due to opioids slowing down the GI tract. And then always naloxone is going to be our antidote of choice here. Works very quickly. Just remember, withdrawal is the main side effect. So if you have a patient who's chronically on opioids, you put them into withdrawal, they're not going to die from that. They're going to probably wish they were dead because it's so unpleasant. However, just know that's going to be the main side effect, right? Keep in mind that when you draw a UDS or when you're getting UDS done, just remember that a lot of opioids do not show up on that. They're really looking for things like codeine, heroin, morphine. Methadone is not going to show up unless they screen for that specifically. Oxycodone may not even show up. Fentanyl is not going to show up. So just because someone has a negative UDS and they're comatose and respiratory depressed and miotic does not mean that they did not abuse an opioid, right? And a lot of times you just give them Narcan. If they wake up, you have your answer right there anyway. So again, Narcan, though, it has a very short duration of action, maybe only 20-30 minutes. So you may have to give repeated doses depending on the half-life of the drug. Methadone may stick around for days. In those cases, you may have to give a Narcan drip to keep them awake and breathing. Up next, we have our hallucinogens, and this is a pretty wide category, but it includes things like LSD, mescaline, psilocybin, our magic mushrooms, nutmeg even. I'm sure some people didn't know you could abuse nutmeg. I would not recommend it, not from personal history, but it is a very harsh high. I've seen some very nasty effects with that one. Even some toads have hallucinogenic compounds they secrete in their skin. So if you hear someone licking toads, that's what they're usually doing it for. So typically, these are working through serotonin, and you can expect to see kind of a sympathomimetic sort of picture. You expect them to see maybe some mild tachycardia, but the main CNS effects are going to be usually stimulatory. They're typically going to have, hallucinations, may have some panic attacks, if they have like a bad trip, things like that, typically dilated pupils. So that's the kind of things you expect to see from that standpoint. But mainly it looks like a sympathomimetic, typically not as bad as something like cocaine or amphetamines. Typically, treatment's pretty supportive for these patients. You can do some GI decontamination for things like mescaline or psilocybin, but LSDs tend to be pretty rapidly absorbed. A lot of times you're probably going to eat these patients after an hour after ingestion anyway, so usually it's not going to be a big concern there. Certainly, cardiac monitoring is important here. Try to put them in a nice, calm, cool environment if possible with some verbal reassurance, especially if they're having a bad trip, and you can inform them that, no, there are no monsters on the walls, no one's coming to get you, things like that. And if they're still having severe agitation, usually we recommend using benzos, Ativan, midazolam, anything like that is very useful to get them to calm down to some degree. Up next, we have cocaine, which is going to be, usually I see this abused more in like inner city sort of areas. So this was really big in downtown Jacksonville where I did my fellowship. However, when you get more rural, that's where you're going to see more use of things like amphetamines. But cocaine here, we're going to find that there's several different ways to utilize it. You can snort it or insufflate cocaine. It can be smoked in some cases. That's where crack cocaine comes from. It's a different form of the drug that can be smoked. And then IV injection is another big one. So typically this is working by blocking reuptake of things like norepinephrine and dopamine. And so that's where you see a lot of the toxicity from it. And so again, this is kind of one of the prototypical sort of stimulants you would expect to see causing the sympathomimetic toxidrome. Typically, you see a lot of CNS stimulation, seizures are possible here, a lot of tachycardia, hypertension. Those are the big things you're going to expect to see. But certainly, dysrhythmias are possible here, and seizures are going to be the kind of the most life-threatening sort of things. Typically, you're going to find that treatment is very supportive. Cocaine has a relatively short half-life in comparison to some of these other substances here, so try to support them. Cool them down if they're hyperthermic. Give them lots of fluids, and then if need be, treat seizures with things like benzodiazepines, maybe even phenobarb if that's treatment resistant. And then from the cardiac standpoint, for the hypertension tachycardia, some people will recommend never giving a beta blocker to someone who's cocaine toxic. I think as long as you give a beta blocker plus a antihypertensive, so like a nitroglycerin or a nicardipine, nitroprusside, anything like that, to get a balanced effect on both the blood vessels and the heart rate, that can be a good combination. Typically, though, you don't need to treat the hypertension or tachycardia just by giving them benzos and fluids. That's usually enough to kind of get them to calm down and will bring the vitals down as well. Next we have our amphetamines, and so again, this is another one that falls into that sympathomimetic sort of category there. So again, very similar effects to cocaine with a little bit different flavor here. Keep in mind this includes all of your ADHD meds that are amphetamine based, so all of your Adderalls, your Ritalins, Concertas, all of that falls in this category, along with things like crystal meth, things like that. Even your bath salts are pretty close to amphetamine as far as toxicity goes. Again, tachycardia, hypertension, hyperthermia, these are all things you're expecting to see with these agents, and typically they're used orally in a lot of cases. You notice cocaine's not really used orally ever. However, amphetamines tend to be a little bit more bioavailable from a GI standpoint. Methamphetamine is probably one of the biggest ones you kind of think about. This is one of those things where pseudoephedrine was being utilized to make crystal meth in a lab, but so that's why basically it's behind the counter now. I have limits on how much Sudafed you can buy. That's one of the more commonly ones. Amphetamines are illicitly made. Usually you're going to find that the onset is pretty quick, and then this lasts much longer than you see with cocaine. So usually, up to 24 hours potentially you could be seeing the effects of these amphetamines sticking around. There's also MDMA, which is methylene dioxymethamphetamine, otherwise known as Molly. This is going to be a different flavor because it actually works more on serotonin than you would see with like typical amphetamine or methamphetamine. This is where you're going to find that because of that, it acts as what we call an enactogen, which basically means it makes you very kind of touchy-feely, very huggy. So it's kind of interesting from that standpoint. But the other big thing with ecstasy is it can actually cause SIADH. And you also can end up seeing these kind of like really kind of repetitive sort of movements, and that includes drinking water. So you get kind of this polydipsia that occurs. And so SIDH plus polydipsia, you can definitely see hyponatremic seizures develop due to that. So that's kind of a unique thing you might see with ecstasy. As far as treatment goes, mainly supportive. Benzos, again, for agitation, seizures. Might need something like nitroprusside or labetalol for the hypertension. Typically, I don't see hypotension with these patients, so you don't really need pressors very often. But again, this can induce MIs, dysrhythmias. You're going to treat all of those just like you would for any other medical sort of patient. Again, the big thing here is just that you want to keep the patient cool, try to get their vital signs under control. Up next, we have our neuroleptics. So these are mainly going to be all of our antipsychotic drugs. I will tell you the ones you see most commonly are going to be things like Haldol, and the phenothiazines are going to be the other big group. So things like chlorpromazine or thorazine, compazine, Phenergan. Those are the more common ones you're going to run into. They all have pretty similar toxicity for the most part. Typically, the side effects are going to be due to the antidopaminergic effects. So that's where you're going to see things like the extrapyramidal effects, the Parkinson sort of effects. They have like akathisia, dystonia, and whatnot. They're also going to be pretty anticholinergic in a lot of cases. So again, you can see all of those anticholinergic toxidromes seen with that. Some of these also cause hypotension due to being anti-alpha sort of effects there. The other big thing to watch out for is going to be the QTc prolongation that you can end up seeing due to potassium channel blockade on the EKG. So again, most of these can cause some degree of QT prolongation, especially if you're mixing multiple meds together. So definitely get an EKG for these patients anytime you have a neuroleptic exposure. Now, typically, we mentioned in the psychiatric med section, we talked about low potency agents and high potency agents. And that has to do with the dopamine sort of effects. Remember that the more high potency anti-dopaminergic drugs like particularly Haldol and fluphenazine, they tend to have more likely to see those Parkinson-like effects, the EPS, and also that can manifest as neuroleptic malignant syndrome. The low potency ones, so typically like your phenothiazine, your thorazine, they tend to be much more anticholinergic, much more antiadrenergic sort of effects there, right? Mainly you're going to see as far as treatment goes, mostly supportive for the most part. However, one thing to remember is that they're having an acute dystonic reaction due to the antidopamine effects. You can actually treat that with an anticholinergic. So in those cases, you give Benadryl most frequently, but certainly something like benztropine, Cogent is a brand name for that, or trihexyphenidyl or Artane. Those can also be used as well. Benadryl gets used most frequently though. From sedative hypnotic standpoint, we talked about benzos already, but certainly there are other agents that fall in this category. This includes a lot of your skeletal muscle relaxants, so things like your baclofen, your cyclobenzaprine, but barbiturates also fall in here. And then even some drugs like GHB, which was used popularly as a date rape drug for a while there. And then a lot of your Z drugs like Ambien, Lunesta, things like that. Again, main thing you're going to see is CNS depression. Typically with things like your barbiturates, you're going to see a little bit more hypotension you can develop with that. And again, when you start to mix these together, that's where you're more likely to see respiratory depression. Treatment mainly is going to be ABCs. You can use charcoal if we were within an hour. However, you need to kind of assess their CNS status, and if they're so sedate that they're not really protecting the airway, I wouldn't do charcoal. And then for the for phenobarb specifically, you can use enhanced elimination with alkaline diuresis, but that only works for phenobarb. Okay, flumazenil, good for the benzodiazepines. Any of the other ones though, they do not have an antidote. So the best thing you can do for them is intubate if necessary. Otherwise, just let them sleep it off. Lithium, another drug we'll use for bipolar disorder. Typically, you're going to find that you can have patients who are having an acute ingestion, or trying to maybe self-harm, or maybe a kid got into it. It will present a little differently than the chronic sort of ingestion. This is another one similar to digoxin, where if a patient's renal function changes on them or renal function declines over time, and you don't address the dose, this is where you kind of have those chronic ingestions. The problem with lithium, very similar to aspirin, is you're going to find that the more of it that's into the CNS, the more likely are to see a lot of serious side effects. And that's more seen with the chronic patients because lithium, it's a small charged molecule, so it has a hard time crossing that blood-brain barrier. Now, this is another one where we can actually get levels for it. So you want to be getting serial levels for these patients to see where the trend is heading, essentially. Typically, levels you're shooting for, usually around 0.6 to 1.2. You probably don't want to get much above that. And certainly levels like 2, 3, that's where you're going to start to see a lot of the CNS sort of effects from this. One other unique thing you might see with lithium is going to be a diabetes insipidus. So certainly you can have, polyuria, hypernatremia seen with this. So be watchful for that. So you can definitely see some electrolyte changes with lithium. The higher your level starts to rise, you're going to start to see things like fine tremor. You're going to start to see more CNS effects, and really the seizures are the biggest things we're really worried about. Basically some EKG changes, but it's the CNS effects I'm really kind of most concerned with. And so you want to really pull that off once you start to see, especially really chronic levels, above 2. That's where we're like, okay, how can we get rid of this stuff? And we're going to find that actually dialysis is one of the best ways to do that. Now again, you want to typically get lithium levels, starting out probably every 2 hours or so. You can get space them out a little bit further than that if it's a more chronic ingestion. You just want to see where the trend's heading. Now remember, this is a metal, so charcoal is not going to work for this. However, potentially you may lavage it, but a lot of those tablets are usually too big to get in there. The big thing you're going to note here is that you want to give lots of saline. Because the lithium looks a lot like sodium to the kidneys. If you have a lot of sodium on board, your kidneys are going to get rid of that, and then if sodium is being expelled from the kidneys, then lithium will go along with it. So by giving them pretty hefty doses of maintenance fluids of normal saline, that actually helps to increase elimination of the lithium there. So that's one thing we'll normally do. If their levels are getting higher than that, we starting to see CNS effects or we're starting to notice their levels are climbing, we'll also initiate dialysis. And so we'll get them nephrologist on board. That'll help us to get rid of that with a 4-hour session, and then generally give time for the stuff in the CNS to kind of partition back out into the blood, and then you may need a second round of dialysis potentially. But dialysis is the big thing to get rid of that lithium. They actually have carbon monoxide poisoning. Now, this is something we're going to see mainly with like house fires. It's going to be a big thing. But the other thing you're going to notice here is going to be from either like cars running in garages, potentially, someone putting the exhaust, putting the hose into their car for self-harm. The other big thing a lot of people don't think about, though, in Florida is during hurricane season, we can actually see carbon monoxide poisoning from generators. People trying to run their generators in the house, they can definitely start to see carbon monoxide poisoning. Or if they're like trying to run a grill, like a charcoal grill, in their garage or in their house, that's another case where you can potentially see that. And there's even some paint remover. Methylene chloride is actually another thing that can actually generate carbon monoxide. Anywho, biggest thing here is that CO is going to go ahead and displace the oxygen off the hemoglobin and turning it into carboxyhemoglobin. Right, so you can get the oxygen from the lungs just fine, but all the hemoglobin's being bound up by carbon monoxide. You can't really transport to the tissues. So as the levels start to climb up, and you're going to be able to measure this on an ABG with co-oximetry, you're going to start to see increasing sort of effects here. And again, this is another case where kids are going to be more affected than adults will be at lower levels. So for instance, a kid may have much more symptoms, say at 10% than an adult might, due to the fact that they are much more metabolically active. They have a lot of oxygen needing in the brain. The other thing I also will ask about for these patients is, are there any animals in the house? Because typically small animals breathing in this carbon monoxide will start to act funny. They may start to be laying around when normally they'd be up and moving, and that can be indicative of more kind of environmental sort of exposure. But normally, as the levels start to climb, headache is going to be one of the first things you're really going to start to notice here, and also a lot of dyspnea on exertion, because again, they're carrying less oxygen in the blood. And then as they get to higher and higher levels, you can start to see CNS effects, start to see syncope. MI can be precipitated with this, seizures, and then obviously coma and death is always going to be the biggest thing we're concerned with. Now, there's also a delayed neuropsychiatric syndrome that can develop in patients who are after the initial carbon monoxide exposure. It can develop several weeks afterwards. But as far as treatment goes, the biggest thing is to make sure you're monitoring your carboxyhemoglobin levels. And the actual antidote here is oxygen. By giving them high amounts of oxygen via non-rebreather, usually 100% O2 via non-rebreather, you can actually decrease the half-life of carbon monoxide. So normally, if I was just breathing room air, carbon monoxide has a half-life of around 6 hours in the blood. If I give 100% oxygen via non-rebreather, it's down to about 1.5 hours, 2 hours. Now, what I could do that's even better is if I could give them hyperbaric oxygen, or basically I would put them into a hyperbaric chamber, similar to what you would do for divers who are having the bends, right? And you would increase that pressure to about 2.5 to 3 times normal atmospheric pressure. And that will actually help to saturate the blood with even more oxygen, and you get the half-life down to like 20 minutes, right? Problem is, it's very difficult to find hyperbaric chambers that will allow you to take these patients to them. For instance, when I was working up in Jacksonville, we had one at Baptist downtown who was not taking any patients. They only did it for like wound care, so they're only open like Monday through Friday during the daytime, so it really didn't help us out in the middle of the night. And then there was one in Gainesville. Usually it was very difficult to make the case that someone needed hyperbaric oxygen, but if they had very high levels, or if they had a history of seizures, or say syncope, or if they're pregnant, that was another big reason why I can get them life flighted over for hyperbaric pretty easily. And usually the level will matter here as well. So again, if their levels are greater than 25, some people may say 30, 35%, that may also be another indication. But definitely give them 100% oxygen via non-rebreather. That's going to be the best thing for the majority of patients who are exposed to carbon monoxide. Next, we have our insecticides. This is going to be mainly we're seeing organophosphate based insecticide. We don't use these very frequently here in the US anymore because they are so dangerous, and we have better agents that are safer nowadays. A lot of the ones we use now are called pyrethrins, which have very little very little sort of side effects for people. However, these organophosphate insecticides you may still see used like industrial purposes in some homes. So basically, these are working by binding to acetylcholinesterase. They're going to inhibit it, and basically you're going to develop a cholinergic toxidrome. We've covered this before. Some people use sludge. I like to use the dumbbells because that includes your killer bees of the bradycardia, the bronchorrhea. Just know those are the main muscarinic effects. There's also nicotinic effects that can happen here as well. Remember, that's the days of the week. Remember that mydriasis, the tachycardia, weakness, hypertension, and fasciculations. That's the main thing you're going to see from the nicotinic effects. However, usually they're going to be predominantly showing muscarinic effects when the patients present to the ER. Treatment is a big thing here is because these organophosphates are very lipid soluble and they can be absorbed through the skin, you have to get rid of all the clothes and make sure to wash off the patient with soap and water if you think dermal contamination happened here. Certainly you can consider using like lavage if it's within an hour or so. Charcoal is probably not going to be super useful with this due to either aspiration risk, and also a lot of these are liquids, and so charcoal has a harder time absorbing liquids, and they usually pass through the stomach pretty quickly. I've never really used cholestyramine before, but theoretically that could be used as an alternative, but not typically used. However, one of the big things we're going to do for these organophosphates is actually to utilize pralidoxine, or another name for it is 2-PAM. We use 2-PAM that actually will help to regenerate the acetylcholinesterase, will help get the organophosphate off of it, and then we'll also use atropine. Atropine is another drug of choice here because that actually will antagonize the muscarinic receptors and try to relieve the patient of the dumbbell symptoms, essentially. Next, we have our alcohols. I think this is the last thing we're talking about today. Certainly ethanol is going to be one of the most common things you're going to run into. It's a very common co-ingestion for a lot of people when they come in presenting for toxic ingestions. Usually people are going to be metabolizing around 20 milligrams per deciliter per hour. So, and usually 80 is like the legal limit for driving. So you can kind of guess when people are actually legally sober is when they end up getting below that 80 milligrams per deciliter sort of level there. Anyway, typically for these patients, you just want to give them some fluids. You can give them multivitamins, especially if they're like really chronic alcoholics who are malnourished chronically. Other than that, mainly supportive care, right? Some patients have to be intubated due to CNS depression, but it just depends. The ones we really want to be worried about are going to be things like methanol and then ethylene glycol. Methanol is normally found usually in windshield washer fluid or potentially in gasoline antifreeze. So you see these ingestions a lot more up north where it gets a lot colder. You don't see them here too much. The problem with these substances is not the actual the alcohol itself. It'll make you drunk for sure. However, the alcohol itself is not really a big issue. What ends up happening though is it gets metabolized into formaldehyde and formic acid and can cause a very severe acidosis and can actually cause retinal damage. And so classically, you describe these patients drinking methanol as having snowfield vision. And so you have to do a fundoscopic exam on those patients. You really have to make sure you're checking them, their sight, and make sure there's no, things like papilledema, no retinal changes you're seeing there. Now, one way we can actually treat this is to actually inhibit alcohol dehydrogenase by giving it more alcohol. So basically by allowing it to metabolize ethanol instead of the methanol, you avoid producing that formaldehyde in this case. And so we used to give alcohol drips to these patients, or if you didn't have IV alcohol available, you could actually use just PO alcohol, right? So I could use grain liquor and treat those patients, and basically by keeping the alcohol dehydrogenase busy, it gave my the body time to excrete the methanol through the kidneys. That takes a long time, and also you had to keep your patient drunk for a couple of days, which was maybe good for the patient, but not necessarily good from our standpoints. And so now we have a better drug called fomepizole, which it does the same thing, inhibits alcohol dehydrogenase, but basically is going to prevent them from forming the formaldehyde, but doesn't get them drunk, essentially. The other thing was going to be is dialysis. That's the quickest way we can actually help pull off those acids. It'll pull off the formaldehyde, it'll pull off the methanol, and it can correct the patient. So very frequently we just say, let's just dialyze them and get it off and be done with it. Similar to methanol is going to be ethylene glycol. The main toxicity you're going to see with this, though, is actually going to be due to renal damage, right? And so again, this gets eliminated in the urine. So if that patient has renal failure due to this, you're not going to be able to get rid of it. Similar picture, though, a lot of acidosis, but renal failure is the big thing you're going to see with this one. You're not actually going to see any vision changes. That's really going to be with methanol specifically. But what you can actually see is you have calcium oxalate can precipitate in the urine that can cause interstitial damage to the kidneys, can cause hypocalcemia potentially. Treatment's actually going to be the same as methanol. Basically, dialysis is going to be a big thing. Fomepizole or potentially IV alcohol are the main treatments for that. And then the last thing is going to be isopropanol or isopropyl alcohol, rubbing alcohol. It's actually very intoxicating, very similar to just like alcohol is going to be, but it's actually going to be much more intoxicating than alcohol actually is. So some people just like to drink it as an alternative to alcohol because it's a lot cheaper in a lot of cases. Generally, we don't need to use dialysis to get rid of it. However, just note that with isopropanol, it actually gets broken down into acetone, and acetone can actually be seen as depressing as well. So patients can stay relatively quote unquote drunk for quite a long time due to the acetone that's sticking around from the isopropyl. The other thing with isopropyl, it's very tough on the stomach. You can actually see a hemorrhagic gastritis that develops from that. So anywho, so again, the point of this lecture is not to make you an expert by any means in toxicology. Like I probably could have done this whole lecture over the course of say 2 electives essentially, and I do that. That's what I do for some of my pharm students. So anywho, so the main thing I want to impress upon you is just to know that the ABCs are the most important thing. Stabilize the patient first. Know what labs to get. Know what antidotes go with specific substances, and know to call the experts. Right. So you always call the poison center. They're 24/7. They're a free service. Make utilization of them pretty standard whenever you're dealing with these patients. Even if you're relatively sure you know what you're doing, it's a pretty clear-cut opioid ingestion. Like just call them, see if they have any additional 2 cents to add to the pile there. It may be able to tell you something that you didn't know, or may have a recommendation for some additional labs to test, or things like that. So anywho, again, I apologize for having this up late, but I did have to re-record the whole lecture due to some technical difficulties. And if you have any questions, please let me know. And otherwise, I will see you guys later. Thanks so much. Bye.